Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Today inshallah we will complete explanation of module 102 which we will talking about blood. We will complete talking about blood inshallah. We have stopped last time in erythropoiesis which we will inshallah complete today. So erythropoiesis means the formation of new RBCs, red blood cells. Okay, this process have been done in a lot of sites in the body, and it is different from by the age. Okay, different from one to another one by the age. So in the fetus, okay, the red blood cells and RBCs and all blood cells types like white blood cells, platelets, formation in in fetus in the spleen and the liver. Okay, in the liver and spleen. That's firstly. Okay, after birth, when the fetus grow up after birth, it is be formation in the all red bone marrow. Okay, all bones, any bones, long bone, short bone. Okay, any type of bone. It is a factory. It's work as a factory of the red blood cells. Okay. When after growth, okay, by the age of 20, red marrow, okay, the red bone marrow, okay, in just long bones, okay, become inactive. Turn from red marrow to yellow bone marrow. Turn to fat. Okay. Except some sites like upper humerus. Okay, humerus. It is a long bone. Okay, of the arm. Site of biceps and triceps. Inshallah, we will explain it in anatomy. Inshallah, and the femur bone, also in the leg. Yes. And only with membranous bones like skull, sternum, ribs, and vertebrae, pelvis. All of these bones produce or still production of RBCs. Okay. Now, stage of development. Okay, in red bone marrow, it has a very three main sections. Okay, A, multi-potential. It is from stem cells. Okay, uncommitted, non-specialized stem cells. Okay, turn to by interleukins, turn to red blood cells. Okay, this is the first stage. The second stage, committed stem cells, when become committed, become specialized. Okay. By hormone, its name erythropoietin. Okay, it is very important hormone with us. So, the stem cells by erythropoietin became erythropoietin sensitive stem cells. Okay, became by the action of erythropoietin became to erythrocyte. Erythrocyte will turn to any type of blood cells, RBCs, white blood cells, platelets, etc. So, as we said, this is a photo for the process. Okay? You can just watch to it. Now, let's move to the factors that affecting erythropoiesis. Okay? The first main factor is oxygen supply, which is very important to formation of red blood cells. So, RBCs will be will be increased production in cases like hypoxia. We have last time definition hypoxia that the decrease in oxygen. Okay. So hypoxia, the decrease in oxygen, as in the hemorrhage. Okay. in traumas, in any car accident, for example. Okay, so hemorrhage in cases by loss of RBCs. This is first case. Secondly, in high altitude, the oxygen is decreased. Oxygen supply is decreased. Okay, in cases in heart failure, also the blood, okay, the heart is tired. The blood do not move. Okay, the blood do not move to the body, so the oxygen supply is decreased. Also, in case of lung diseases, there is no naturation of oxygen. Okay. In case also in athletes is need more oxygen to do works. So that's it. Okay. This first case. Also, hypoxia stimulate erythropoietin. That, if you remember, the previous hormone that we said that turn stem cells to erythrocytes. Okay. So hypoxia stimulate erythropoietin that's released from in fetus, released from the liver. In adults, released from the kidney by 85% and from the liver 15%. So the liver in the fetus is very, very important. Okay. Also anemia or anemia developed in the renal failure. So liver cannot compensate. In renal failure patients, okay, their kidneys cannot produce erythropoietin. So there are anemia in the blood. Anemia means there is a low RBCs, low blood cells. So also in cases in renal failure, if we remove kidney, also will produce anemia. Yes. The therapy of renal failure, that erythropoietin, but in vitro. In vitro means from out the body. Okay. Erythropoietin injections is that by recombinant DNA technique. Okay, just information. Okay. The mechanism of action of erythropoietin. Erythropoietin binds specific receptor on erythropoietin sensitive stem cells. It accelerates steps of erythropoiesis. So it is very simple. Erythropoietin just act on stem cell, erythropoietin sensitive stem cells, and accelerate the formation of erythrocytes. The stimulation of secretion of erythropoietin, okay, in cases of hypoxia, as we said, in high altitude means alkalosis, okay, and by androgens like testosterone, okay, like this, and adenosine, okay. He is mentioned here, adenosine antagonist, thiophyllin. Thiophyllin is contained in tea, okay? So inhibit secretion. Okay. So in cases of anemia, okay, there is not preferred to take tea a lot, okay? Because inhibition of erythropoiesis, or erythropoietin, which make erythropoiesis. That's firstly. Also beta agonist also increase secretion of erythropoietin, and cobalt salt, and hypoxia. And hypoxia is the main stimulus. This is very MCQ information, very important MCQ information. Okay, that is oxygen supply. That was the first factor. The second factor is the hormones. Okay, hormones like thyroid hormones, glucocorticoids like cortisone, okay, androgens like testosterone, erythropoietin itself, Okay, it's very important to increase the erythropoiesis. The thirdly factor is the healthy bone marrow. As we said, that bone marrow is the factor of blood cells. So it is very important to be healthy. Okay. He said that he is site of erythropoiesis. Okay, bone marrow destroyed by X-ray, radiation, antibiotic, okay, malignant tumor. It is very important, okay, that bone marrow destroyers. Okay, if we destroy the bone marrow, what the result? The result will be decrease in all blood cells. Okay, it's called aplastic anemia. Aplastic anemia. A means negative, okay, and plastic means the plasticity, okay. Anemia, that is decrease of all function and all count of red blood cells. Fourthly, healthy kidney. As we said, that 85% of erythropoietin is formed in the kidney and 15 is formed in the liver in adult. So it's very important. Okay, he also said the same information. Fifthly, we have the healthy liver, as we said, because the 15% of formation of erythropoietin, and he stores the vitamin B12 and iron. This is very important. We will discuss this inshallah later. Okay. The sixth factor is the diet. Okay. The diet is very important also to take to formation of blood cells. Proteins of high biological value for formation of globin part of hemoglobin. It's very important to make healthy blood cells, as we said before. Okay. Secondly, vitamins. Vitamins like B12, folic acid, and vitamin C. Also, iron. It's very important to take in diet. So let's talk about first vitamin. We have vitamin B12. Okay. It's also called cyanocobalamin. Okay, cyanocobalamin. Also called extrinsic factor. Also called maturation factor. The all names is important. The most famous name is vitamin B12. Okay. The source of it, animal origin in source, in the liver, meat, chicken. The daily requirements 5 micrograms. Okay, liver stores 5 milligrams. Okay, that's the liver stores vitamin B12 for a long time. Okay, the liver can live without vitamin B12. Okay, out of the body. Okay, can live almost 1 year without meat. 1 year. So that is firstly. The function of vitamin B12, it's very important. Okay, very important for DNA synthesis. Okay, play a main role formation thymidine triphosphate. Okay, and nuclear maturation of RBCs, which is very important. If we don't have vitamin B12 enough, there will no maturation of RBCs. Okay, that will be translated. There is no division of RBCs. Okay, which will make RBCs very large, and it will be very useless and stuck in the capillaries. Okay, that's it. In cases if we do not take vitamin B12, okay, if we take it daily, it will be very healthy. And also share information of myelin sheath in nerves. Okay. The processing of absorption of vitamin B12. Vitamin B12 is absorbed in the stomach firstly. The partial cell of the stomach, okay, secrete intrinsic factor. Okay, intrinsic factor is very important to absorption of vitamin B12. Okay, that is unit with vitamin B12 and protect vitamin B12 from HCl. Okay, in the stomach. And make it down till reach ileum. Any part of ileum, the lower ileum. Not duodenum, not duodenum, in ileum. So, vitamin B12 absorbed in the ileum, in the lower part of the ileum. Okay. It's also requires pancreatic trypsin. It's very important also. So, vitamin B12 plus intrinsic factor will enter the intestinal cell. Inside the cell, intestinal cell, okay, vitamin free transferred and absorbed to the blood. Okay, the carrier called transcobalamin 2. Okay, distributed and excess stored in the liver. Okay. Now let's move to the causes of the deficiency. Okay, there is a lot of causes of deficiency. Okay, firstly by the failure of absorption. Okay, it's not always that you cannot eat vitamin B12. No, the problem it just be that the failure of absorption. Okay, and it's very famous in vegetarian. Yes. One of these causes is the absence of intrinsic factor. Okay, it's called pernicious anemia. Okay, it's hereditary disease or familial disease of elderly women. Okay, immune reaction against partial or parietal cells in the stomach. So cell destruction and decrease the HCl, hydrochloric acid, and intrinsic factor. Okay, that's the first cause. The second cause is the gastrectomy. In gastrectomy, there is not enough time to bind intrinsic factor with vitamin B12. So the HCl destroy the vitamin B12 inside the stomach. Okay, the third cause also the decrease in absorption, as we said before. Okay, diseases of lower ileum. Okay, diseases of lower ileum, which is the site of the absorption of vitamin B12. The fourthly cause of deficiency is the decrease the store in liver diseases. Okay. Let's move now to the effects of deficiency, like macrocytic anemia. Okay, bigger irregular fragile cell. Why? Because there is no division of RBCs, because their vitamin B12 is very important for the division, okay, to complete maturation of DNA. The treatment simply vitamin B12 injection. Okay, this is the first vitamin. We have vitamin B12. Okay, let's move to the second vitamin we have. It's called folic acid. Okay, folic acid. The source of it's from vegetables, from fruit, liver, meat, okay, and destroyed by cooking. Okay. Function essential also for DNA synthesis. Effect of deficiency, it's like vitamin B12, the macrocytic anemia. Causes of deficiency: decrease in intake, okay, in cases of starvation, and increase in needs like pregnancy, okay, decrease of the absorption in disease of small intestine, okay. The treatment of cancer with antifolate cytotoxic drugs, okay, methotrexate. Methotrexate is a drug, okay, for cancer. It causes folic acid deficiency. Yes. So those two vitamins, the same effect of deficiency. It's called macrocytic anemia, which is very important MCQ information. Now let's move to the third important minerals in RBC's formation. It's called iron. Iron, the total body of iron is the 4 gram. Okay, it's closely to 4 gram. Yes, 4 gram. Okay. 70% of it for formation of hemoglobin. Okay, it is recycled. 3% of it for formation of myoglobin for the muscle. 2% of it part of many oxidative enzyme. Okay, catalase, peroxidase, cytochrome, and 25% of it is stored in the liver, in the spleen. Okay. In case it's called ferritin. Yes, ferritin. As we said before, ferrous is absorbed and ferritin is the case the stored, okay, storageable of iron. Yes. And very small part of iron, okay, in plasma. Yes, it's moved freely in plasma. Okay, 130 microgram per deciliter in male and less of it in female. Yes. You need daily, okay, every day from iron 30 milligram for heme synthesis. Okay. The most of it, as we said before, it's from recycled iron. Okay, because there is no excretion way for iron in the body. So the increase of iron in the body is very dangerous. Okay. Iron loss, as we said, sloughed in epithelial cell, hair, sweat, and any blood loss. Okay. An adult male, he is lost nearly to 1 milligram per day. In female, higher. Okay, because menstrual cycle. Okay, so she lost 2 milligram per day. To maintain iron balance, amount of absorbed nearly equal the daily iron loss. Okay. So, an iron absorption, transport, and storage mechanism. Firstly, absorption from the diet. Okay, intake from the diet. So, diet has two forms of the iron. The first form is the heme, which in the meat is 10% of dietary iron, most readily absorbable. Okay, it's very fastly to be absorbed. And the non-heme form of iron in vegetables, in cereals, in beans. Okay, it is 90% of dietary iron. Okay, it's less absorbable. most dietary iron in ferric form. Okay, it is not absorbable. Fe3, it's not absorbable. Okay. By vitamin C, which is called ascorbic acid, and gastric hydrochloric acid, okay, dissolves the ferric iron and turn it to the ferrous state. Okay, ferrous form of the iron is absorbable, as we said before. Also phytic acid and oxalate phosphates, okay, decrease the absorption. So it's okay. And duodenum is the main site of absorption. Okay, the sites of absorption is very important. Okay, in question. So duodenum is the main site of absorption of iron. Okay, bioreductase enzyme for iron not reduced in the stomach. Okay, DMT1, divalent metal transporter 1, transport iron in ferrous state, okay, in ferrous form into enterocytes. And heme carrier protein HCP1 transport heme into enterocyte. So, as we said, DMT transport the iron itself, and heme carrier protein transport the heme itself, all into enterocyte. Inside the enterocyte, if no demand, iron stored as ferritin. Okay. If increase the demand, iron is transported to blood via ferroprotein, okay, at basolateral border and oxidized by ferroxidase enzyme to F3, ferric state. Okay, in the blood, iron ferric state carried by transferrin, okay, 35% saturated with iron, to bone marrow, to muscle, to liver, and the spleen. Yes. Let's move now to regulation of iron absorption, or we can call it iron homeostasis. Okay, it is regulate the absorption only. As we said, there is no mechanism of excretion or regulation of excretion. So the first type of regulation is from dietary, from intake. So increase iron in food, decrease DMT1 on enterocyte. DMT1, as we said, it's transporter of ferrous form of the iron. So the decrease, so equal decrease the iron absorption. There is also hepcidin. Hepcidin is hormone, okay, secreted by the liver. Inhibit iron absorption. Okay, it is bind with ferroprotein. Okay, so inhibit the intestinal absorption of iron, and inhibit intestinal absorption from in the duodenum. Okay, the duodenum, and inhibit release of recycled iron from macrophage, and inhibit release of iron from the liver and other store sites. So hepcidin is the antagonist of the iron. Okay, simply that's it. Okay, now let's move to the factors affecting the hepcidin secretion. Simply, if we increase the hepcidin, the iron will be decreased, and the opposite. In hypoxia and erythropoietin status, that we need iron to formation a lot of red blood cells, we do not need hepcidin. So hepcidin is decreased in hypoxia and when erythropoietin secreted. Okay, there will decrease hepcidin secretion and increase iron absorption and release. Okay. In a state of inflammation and iron overload, okay, we do not need iron. We do not need iron. So we need more hepcidin to prevent any increase in iron. Okay. Anemia is common in inflammatory diseases. Okay. Now let's move to the effects of iron disturbance. In iron overload, increased of iron, okay, there is increase in ferritin. Leads to hemosiderin deposits, okay, hemosiderosis in tissue, result in skin well pigmentation, okay, pancreatic damage, become bronze diabetes, okay, that skin will be more like orange in color, liver will be have cirrhosis, okay, and become fatty liver, and increase incidence of hepatic carcinoma. Okay, so iron in overload, when increased a lot of iron, okay, it's very dangerous, as we said, because there is no excretion mechanism of iron. In case of iron deficiency, the opposite, result in microcytic hypochromic anemia. Okay, as we said before, because iron, it's essential for formation of normal blood cells. If we don't have iron, there is no normal blood cells in count and also in the structure. So the causes of deficiency is, or let's back to the name, microcytic and macrocytic. Macro, okay, in A letter, means large. Okay, but micro means small. Okay, hypochromic, hypo means decrease. Okay, so in cases of iron deficiency, there is microcytic, okay, small sized of red blood cells, and hypochromic, small or decrease in the content of RBCs. But in cases of vitamin B12 or folic acid deficiency, it will be macrocytic deficiency, that it is large, okay, didn't division yet, because there is DNA, okay, DNA damage. Okay, so let's go to the causes of deficiency of iron. Firstly, decrease in intake in growing children, pregnant females, okay, or in starvations like this. Secondly, cause is the decrease in absorption, okay, partial gastrectomy if we remove the duodenum, okay, decrease in the HCl, vitamin D deficiency, as we said, because the vitamin C turn the ferric state to ferrous state, okay, increase the phytic acid and oxalate and phosphate in diet, and diseases of duodenum. Okay. Thirdly is the chronic blood loss. Okay, chronic blood loss. If there is a bleeding, okay, inside the body, small bleeding inside the body, that hard to be noticed, okay, well, the result will be the deficiency of iron. Yes. The case of chronic blood loss is bleeding, peptic ulcer, piles, excessive menstruation, okay, and cyclostomasis, okay, like this. Now let's go fourthly by to trace elements, okay, like cobalt and copper, okay, those are a cofactor for hemoglobin synthesis. So it is very important, cobalt and copper. Cobalt specifically stimulates erythropoietin secretion, okay, and it is a part of vitamin B12 formation. So cobalt is very important element. Now let's go to the another case, okay, differ from the other. It called polycythemia. We mentioned polycythemia in the previous lecture. Polycythemia means increase of the red blood cells, increase, and this is definition: increase number of red blood cells, okay, from 6 to 8 millions, okay. Types of it: primary and secondary, okay. Primary called polycythemia vera, secondary called just polycythemia. For the primary type is due to diseases in the bone marrow that increase white blood cells and platelets, okay. So primary is due to disease, primary with disease. Secondary type with hypoxia, yes, in obstructive lung disease and at high altitude, okay. That's simply primary. Just can be cancer in bone marrow, okay, that increased the blood cells count, okay. Secondary, as we said, in hypoxia, okay. Now let's move to the anemia, which means decrease oxygen carrying capacity of blood, okay, due to increase number of RBCs or increase the space that can carry oxygen, is called hemoglobin content, okay. Below 4.5 million, okay, per microliter in males, and less than 3.9 million per microliter in females, okay, that number of RBCs. The number of hemoglobin content is below 13.5 gram per deciliter in males and below 11.5 gram per deciliter in females. There is a classification and causes of anemia, that is specifically, okay. We have mentioned it before like this. Firstly, we have normocytic normochromic anemia. Normocytic normochromic anemia. It's from its name, okay. Normocytic means the size of red blood cells is normal. Normochromic, the content of blood cells is also normal. Anemia, so that means just the number of red blood cells is get less, okay. So that's mean the decrease in the number, okay. But normal MCV, inshallah, these MCV and MCH, okay, we'll discuss it specifically inshallah in the practical, inshallah. Here just for reading, okay, like it. So that's it. Cause of normocytic normochromic anemia is hemolytic anemia. Firstly, hemolytic anemia means increase the breakdown, okay. That causes jaundice. Jaundice means that the body color tends to the white, okay, in liver diseases, okay. Firstly, in intrinsic disorders, okay, like hereditary spherocytosis, that red blood cells do not become biconcave like this, no, it become spherical in shape, like this, like a ball. So as we discussed before, the ball shape of RBCs give less capacity to pick up oxygen with it, okay. Secondly, G6PD deficiency, okay. It's also congenital, okay, anomalies in the fetus. This hormone is essential for glucose, okay. It is if it is not exist, will make hemolytic anemia. And thirdly, sickle cell anemia, okay, we will discuss it inshallah later. And this is for A, intrinsic disorder. For B, extrinsic disorder like bacterial toxins, chemical drugs, okay, erythroblastosis fetalis. This, inshallah, we will, if we reach to the ABO system and RH system, inshallah, we will know it specifically. Yes. Inshallah, we'll discuss it, inshallah. Very good, inshallah. And then finally, incompatible blood transfusion. For example, someone have A, okay, A positive, we transferred B negative for to it, okay, it will make hemolytic anemia. Thirdly, in hemorrhagic anemia, okay, in acute sudden rapid blood loss, okay, like any trauma, like any hemorrhage, okay, any type of hemorrhage. So body tries to replace plasma in 2 days, okay, and RBC is replaced by 4 to 8 weeks. Okay. The fourth cause to normocytic normochromic anemia is aplastic anemia. Decrease in all blood cells, as we said, and vitamin B12 and folic acid deficiency causes bone marrow depression. Okay, a lot of causes, inshallah we'll discuss it. Second type is microcytic hypochromic anemia, or it's called specifically iron deficiency anemia. Means microcytic, small size in red blood cells and small content of it. Decrease in number, decrease in MCV, decrease in MCH. Okay, causes iron deficiency and thalassemia. Okay. Microcytic anemia, it's called megaloblastic anemia. In megaloblastic anemia, as we said, in vitamin B12 deficiency and folic acid deficiency. Okay. Okay, no problem. I have been confused. Okay. Aplastic anemia is the decrease in all blood cells. Okay. Just like a cancer in bone marrow. Okay, that make a lot of red blood cells, a lot of blood cells. Okay, white blood cells, platelets, RBCs, etc. But megaloblastic anemia, that's make a large, okay, of RBCs because vitamin B12 deficiency and folic acid deficiency. Okay, now let's talk specifically on causes of normocytic normochromic anemia. Okay, first, hereditary spherocytosis. Okay, that hemolyze more than normal biconcave cells. Okay, caused due to mutation in proteins that maintain flexibility of the membrane, and you can see the difference. Okay, spherocytosis and normal biconcave blood cells. Okay, the second disease we have that G6PD deficiency. It is an enzyme, okay, it's very important and required for initial steps of glucose oxidation. Okay, this pathway generate NADPH. NADPH reductase enzyme in RBCs needed to produce reduced glutathione, which is an antioxidant. Okay, congenital absence in G6PD will cause hereditary methemoglobinemia. Yes, and we discussed it before in previous lecture. Sickle cell anemia. Okay, normal hemoglobin is replaced by HbS, hemoglobin S. Okay, this hemoglobin, okay, this type of hemoglobin Participate inside RBCs at low oxygen tension. Okay. Make the RBC that sickle cell shaped. Okay, you can see here like this. Thalassemia cause decreased or absent of alpha or beta chain of hemoglobin. Okay, one of cause of hemolytic anemia, produce microcytic hypochromic anemia. We discussed it before. And that's what we all have today, inshallah. Thank you for good listening. Inshallah, we will complete, inshallah, in next lecture. Thank you for listening and have a nice day. Assalamu alaikum.